Hey everyone, welcome back. Today we're doing a deep dive that's particularly relevant for all of us medical microbiologists out there.
Oh, definitely.
It's acute bacterial osteomyelitis.
Absolutely.
And we're going to be using the World Health Organization's Aware book as our guide for this deep dive.
A great resource.
Yeah, it's a fantastic book, and we're going to be focusing specifically on chapter 35, which is dedicated to this topic.
Yeah.
So we're going to be hitting all the key points, starting with the definition.
Of course.
Recognizing those telltale signs and symptoms, those clinical presentations.
Yeah, absolutely.
And then we'll dive into those essential lab tests and imaging studies that help us clinch the diagnosis.
Absolutely. Got to have those tools.
Yeah, and then we'll tackle those treatment strategies.
Of course.
Thinking about those sometimes tricky antibiotic choices and dosages.
It's always a challenge.
Yeah. And then to make sure you're truly prepped, we'll wrap up with a quick fire round of exam-style questions.
Yeah. Got to put that knowledge to the test.
All right. So are you ready to dive in?
Absolutely. Let's do it. You know what always strikes me about acute bacterial osteomyelitis is how it really highlights how interconnected different medical specialties are.
Absolutely.
We've got the microbiological aspects, of course, but we also need to understand the clinical picture, the radiology findings, and even surgical considerations.
It's like a medical mystery.
It really is.
Where we have to piece together all those clues from these different disciplines to solve the case.
Exactly.
So, but before we get ahead of ourselves,
sure,
let's start with the basics. How does the WHO define acute bacterial osteomyelitis in the Aware book?
They define it as an infection of the bone that involves inflammation and destruction. It's simple enough, right?
Yeah, it sounds straightforward.
But as always, the devil is in the details. And understanding those nuances is crucial for effective diagnosis and management.
Absolutely. So let's unpack some of those details then.
Sure.
The book mentions 2 classification systems for acute bacterial osteomyelitis. Could you break those down for us?
Absolutely. So the first system focuses on the source of the infection. Okay. So we've got those cases where the bacteria spread through the bloodstream. That's called hematogenous osteomyelitis.
Okay.
Then there's local spread where the infection kind of creeps in from nearby tissues.
Right.
And finally, we have direct inoculation where the bacteria basically get a free pass into the bone, usually through trauma or surgery.
So it's like choose your own adventure for bacteria, right?
Exactly.
Different routes, but same destination, an infected bone.
Yeah.
Now, what about that second classification system?
So the second system centers on how long those symptoms have been hanging around.
Okay.
So we're talking acute versus chronic osteomyelitis.
Right.
Now, the Aware book emphasizes the presence of dead bone, also known as sequestra, as a hallmark of those chronic cases.
Okay.
This isn't something we typically see in acute osteomyelitis where the infection is well more acute.
Right.
It hasn't had time to cause that level of bone destruction.
I see. So that distinction between acute and chronic seems super important.
Absolutely.
Especially when we're thinking about treatment strategies. I imagine those dead bone fragments in chronic cases would make it much harder for antibiotics to reach their target.
You're absolutely right. And that's why recognizing these different classifications early on is so crucial.
Yeah.
It's not just about labeling the infection. It's about tailoring our approach to tackle the specific challenges each type presents.
For sure. Okay, so we've got a solid grasp on the definition and those key classifications.
Yep.
Now let's walk through a typical case.
Right.
Imagine a patient walks into your clinic. What would those classic signs and symptoms of acute bacterial osteomyelitis look like?
Well, think about it this way. An infection in the bone is going to cause inflammation.
Right.
And inflammation means pain, swelling, redness, and warmth.
Okay.
So you're going to be looking for those localized signs at the site of the infection.
So if I'm picturing this correctly,
yeah,
we're talking about someone, limping into the clinic, pointing to their leg and saying, "Doc, this hurts like crazy."
Exactly.
It's all red and swollen. It feels hot to the touch.
Exactly. And they might also have a fever, chills, and other signs of a systemic infection.
Right.
But what's interesting is that those systemic symptoms aren't always present.
Okay.
Especially in certain cases, like when the infection is in the vertebrae hip or pelvis.
So we can't rely on fever alone to rule out osteomyelitis.
Right.
We really need to keep our eyes peeled for those localized signs, even in the absence of those, telltale systemic symptoms.
Absolutely. That's a key takeaway, especially when you're dealing with patients who might not be able to clearly communicate their symptoms.
Right.
Like young children or those with altered mental status.
Now, remember the Aware book mentioned something about delayed fracture healing
Yes.
as a potential red flag.
Yeah.
Could you expand on that a bit?
Absolutely. You see, when a bone is infected, it's going to have a much harder time healing properly.
Oh,
So if you have a patient with a fracture that just doesn't seem to be mending as expected,
right.
osteomyelitis should definitely be on your radar.
Interesting.
It's like the infection is sabotaging the healing process from within.
That's fascinating. It's almost like the infection is creating a distraction,
Yeah,
preventing the body from focusing on repairing that broken bone.
exactly. It's like trying to build a house while someone keeps knocking down the walls.
I like that analogy.
And speaking of distractions, we can't forget about septic arthritis.
Ah, yes. The Aware book mentioned that can sometimes tag along with osteomyelitis,
Right.
especially when the infection is near a joint. So it's like a double whammy
It is.
with both the bone and the joint under attack.
It's more like a domino effect.
Okay.
The infection in the bone can spread to the adjacent joint or vice versa.
Right.
And that complicates things because now you have to treat both infections.
Okay. So we've covered the definition, the classifications, the clinical presentation. Now let's put on our detective hats and talk about how we confirm our suspicions. What are those essential laboratory tests that we need to order when we suspect acute bacterial osteomyelitis?
Well, the WHO is very clear in the Aware book. Targeted antibiotic treatment based on microbiology results is the gold standard, especially for adults.
Okay.
And to get those results, we need to collect the right specimens. So let's talk about the microbiology tests first.
Perfect. So where do we start blood cultures?
Blood cultures are definitely a good starting point.
Okay.
They can help us identify those bacteria that are circulating in the bloodstream. But remember, a negative blood culture doesn't rule out osteomyelitis.
All right.
Those bacteria might be hiding out in the bone itself, not playing nice and showing up in the blood.
So we need to go straight to the source,
Exactly.
the bone.
Yep.
What's the best way to do that?
A bone biopsy is the most definitive way to nail down the diagnosis. It allows us to directly visualize the bacteria under the microscope, culture them, to identify the specific culprit, and most importantly, perform antimicrobial susceptibility testing to guide our antibiotic choices.
So it's like a 3-in-1 package.
It is.
Identification, confirmation, and guidance all in one procedure.
Exactly. And if surgery is part of the treatment plan, grabbing those deep tissue or bone samples during the procedure can give us valuable real-time information.
It's like having a direct line to the battlefield,
Exactly.
allowing us to adjust our strategy as needed.
Right.
Now, the Aware book also mentioned considering those less common pathogens like mycobacteria, fungi, and brucella.
Right.
When should we be thinking about those?
It's all about those subtle clues, those red flags in the patient's history, clinical presentation, and even geographical location that might point us in the direction of those less frequent culprits.
So it's like a mental checklist.
It is.
Travel history, exposures, underlying medical conditions, all those pieces of information
Exactly.
that can help us refine our microbial investigation.
And don't forget about those special stains and cultures that might be needed to isolate those fastidious organisms.
Right.
It's not always as simple as growing bacteria on a standard agar plate.
Right.
Sometimes we need to bring out the big guns to catch those elusive culprits.
Now let's move beyond those microbiology tests.
Sure.
What about those other laboratory tests that can help us in the diagnosis and management of acute bacterial osteomyelitis?
Well, there are a few markers that can give us some clues about the level of inflammation going on.
Okay.
Think about those classic inflammatory markers: white blood cell count, CRP, ESR.
Right.
They're not specific to osteomyelitis, but they can definitely tell us if there's a raging fire going on in the body.
It's like taking the temperature of the immune system.
Exactly.
If those markers are sky high,
Yeah,
we know there's a battle raging.
right. And while these tests won't pinpoint the exact location of the fire, they can definitely tell us how intense it is.
Okay. And while we're on the topic of lab tests, the Aware book also suggests checking calcium phosphate and alkaline phosphatase levels, particularly in adults.
Yeah.
What do you think that is?
Those tests are more about playing detective and ruling out other bone conditions that might be mimicking the symptoms of osteomyelitis.
Okay.
It's like a process of elimination, making sure we're not barking up the wrong tree.
So it's like clearing those innocent suspects from the lineup
Exactly.
before we focus on our prime suspect, acute bacterial osteomyelitis.
Precisely. We need to be thorough and consider all those possibilities, especially in those tricky cases where the clinical presentation might not be crystal clear.
All right, so we've covered the microbiology tests and those other helpful lab markers.
Yep.
Now let's shift our focus to imaging studies.
Okay.
Where do we start? Is a simple X-ray enough to seal the deal?
A plain X-ray is always a good first step.
Okay.
It's readily available, relatively inexpensive, and can give us a general sense of what's going on in the bone. But here's the catch. In the early stages of acute osteomyelitis, those classic X-ray findings might not be visible yet. It's like trying to spot a tiny crack in a wall. Sometimes you need a stronger lens to see it.
So we can't rely on a normal X-ray to rule out osteomyelitis.
Right.
Especially in those early stages, we need to keep our suspicions high, even if that initial imaging study comes back clean.
Exactly. And that's why it's important to correlate those X-ray findings with the clinical presentation,
Yeah.
the lab results, and the patient's overall history. It's like piecing together a puzzle.
Now, if that X-ray doesn't give us a clear answer, what are our next steps? Do we jump straight to an MRI?
Well, there's also a CT scan option. A CT scan can be helpful in certain situations, like when we need a better look at the bony anatomy or when we suspect complications like an abscess. It's kind of like getting a 3D view of the battlefield.
So a CT scan is like getting a more detailed map of the terrain.
Yeah.
While an MRI is more about seeing those subtle changes in the tissues.
Yeah.
When would you choose one over the other?
That's a great question. And honestly, the choice often depends on the specific clinical scenario, the availability of the imaging modalities, and even the patient's individual characteristics.
Right.
For instance, if a patient has metal implants, an MRI might not be the best choice as those metal components can distort the images.
It's like having a toolbox full of different instruments.
Right.
Each with its own strengths and limitations.
Yeah.
We need to choose the right tool for the job.
Exactly.
Considering all those factors.
And sometimes we might even use a combination of imaging studies to get a complete picture.
Right.
For instance, we might start with an X-ray, then move on to a CT scan to get a better look at the bony anatomy, and finally follow up with an MRI to assess those subtle, soft tissue changes.
Okay, so we've covered the definition, the clinical presentation, the lab tests, and the imaging studies. Now let's move on to the main event treatment. What's the WHO's take on tackling acute bacterial osteomyelitis?
Well, as we've already touched upon, the AWARE book strongly emphasizes targeted antibiotic therapy based on those microbiology results.
Right.
That means identifying the culprit, figuring out its susceptibility profile, and choosing an antibiotic that can effectively penetrate bone tissue and reach those bacterial hiding spots.
It's like launching a precision strike.
Yeah.
Making sure we're using the right weapon to hit the target and minimize collateral damage.
Exactly.
But what about those situations where we need to act fast before those microbiology results come back? What's the game plan then?
That's where empiric antibiotic therapy comes in.
Okay.
We have to make an educated guess based on the most likely pathogens and the local resistance patterns. And that's where table 35.5 in the AWARE book becomes our best friend.
I see you've got your copy handy.
I do. Always.
Walk us through that table then. What are those key empiric antibiotic choices that the WHO recommends?
Well, for adults, the recommendations often include a combination of antibiotics to cover those likely suspects, like Staph aureus, including MRSA, and those pesky gram-negative bacteria. So you might see something like vancomycin or daptomycin paired with a third-generation cephalosporin, like ceftriaxone or ceftazidime.
So it's like a two-pronged attack, hitting those gram-positive and gram-negative bacteria with a 1-2 punch.
Exactly. And the choice of antibiotics might also be influenced by local resistance patterns.
Right.
For instance, if you're in an area with a high prevalence of MRSA, you might start with vancomycin or linezolid right off the bat.
So it's not just about memorizing a list of antibiotics. It's about understanding those local epidemiology patterns. And tailoring our choices accordingly. Now, what about those dosages? Does the AWARE book provide specific recommendations?
It does. Table 35.5 not only lists the recommended antibiotics, but also outlines the typical dosages for both adults and children.
Okay.
And remember, those dosages might need to be adjusted based on the patient's weight, kidney function, and other individual factors.
It's all about personalized medicine, finding that sweet spot between effectiveness and safety for each individual patient. Now, what about children? Are the empiric antibiotic choices similar to those for adults?
There are some key differences. In children, we also need to consider pathogens like Kingella kingae and Haemophilus influenza, especially in those who haven't been vaccinated. So the empiric regimen might include something like ceftriaxone or cefotaxime along with clindamycin.
So it's like we're casting a wider net in children.
Yeah.
Making sure we're covering all those potential culprits that tend to target younger patients.
Exactly.
Now, before we move on to those specific antibiotic considerations,
Sure.
let's touch on a topic that the Aware book briefly mentions, prosthetic joint infections.
Ah, yes. Prosthetic joint infections are a whole different ballgame.
Yeah.
They're notoriously difficult to treat and often require a multidisciplinary approach involving both infectious disease specialists and orthopedic surgeons.
The Aware book acknowledges the complexity of these cases,
Yeah.
but doesn't delve into those specific treatment recommendations.
Right.
I guess it's because they warrant a deep dive of their own.
Absolutely. And for the sake of this deep dive,
Yeah.
we'll keep our focus on those non-prosthetic cases of acute bacterial osteomyelitis.
Sounds good. So let's dive into the nitty-gritty of antibiotic treatment.
Okay.
What are those key factors that we need to consider when choosing an antibiotic and determining the duration of therapy?
Well, the first thing we need to consider is the pathogen itself. What's the culprit? Is it Staph aureus, a gram-negative bacteria, a fungus?
Right.
Once we know who we're dealing with, we can start narrowing down our antibiotic choices.
It's like choosing the right tool for the job. We wouldn't use a hammer to tighten a screw, would we?
Exactly. We need to make sure our antibiotic matches the microbial target.
And once we've identified the target, we need to consider its susceptibility profile. Is it susceptible to penicillin, methicillin, vancomycin?
Right.
Knowing its weaknesses helps us choose the most effective weapon.
It's like a game of microbial chess,
Yeah.
trying to outmaneuver those tiny but formidable opponents.
Now, beyond those pathogen-specific factors,
Yeah.
what are some of those broader considerations that influence our antibiotic choices?
Well, we need to think about how well an antibiotic penetrates bone tissue.
Okay.
Some antibiotics are like those elite special forces able to infiltrate those hard-to-reach areas, while others are more like those conventional troops struggling to breach those bony defenses.
So it's not just about choosing an antibiotic that can kill the bacteria in a petri dish.
No.
It's about choosing one that can actually reach those bacteria hiding out in the bone.
Exactly. And we also need to consider the patient's individual characteristics, like their age, weight, kidney function allergies, and other medications they might be taking.
Right. It's all about personalized medicine, finding that sweet spot between effectiveness and safety for each individual patient.
Now, what about the route of administration? Is FI always the way to go?
Historically, intravenous antibiotics have been the preferred route for acute osteomyelitis.
Especially in those initial stages when we need to achieve those high drug concentrations in the bone.
Right.
But the Aware book does acknowledge the growing trend towards earlier transition to oral therapy,
Oh.
particularly for uncomplicated cases and in those who are clinically stable.
So it's not always about those long hospital stays and IV lines.
Not always.
Sometimes we can achieve the same results with a pill, but how do we know when it's safe to make that switch?
That's where clinical judgment comes into play.
Right.
We need to assess the patient's overall condition, the severity of the infection, and their response to initial IV therapy.
Okay.
If they're showing signs of improvement and their clinical status is stable, we can start thinking about that transition to oral antibiotics.
It's like a carefully choreographed dance.
Yeah.
Making sure we're hitting those bacteria hard initially,
Right.
then transitioning to a more sustainable strategy once the patient is on the road to recovery.
Exactly.
Now, what about those specific oral antibiotics that the Aware book mentions? Are there any standouts that are particularly effective for osteomyelitis?
Well, clindamycin is often a top contender.
Okay.
It's got great bone penetration and can be a good option for those who are able to transition to oral therapy.
Right.
But again, the specific choice of antibiotic will depend on the pathogen,
Of course.
its susceptibility profile, and those individual patient factors we discussed earlier.
So it's like a personalized prescription tailored to each patient's unique circumstances. Now, what about the duration of therapy? Is there a magic number?
The Aware book provides some general guidelines, but it emphasizes that there's no one-size-fits-all answer treatment. Duration depends on a whole host of factors.
Such as?
Think about it, acute versus chronic infection,
Okay.
the presence or absence of those foreign bodies or dead bone,
Uh-huh.
a specific pathogen and its resistance profile,
Right.
how well the chosen antibiotic penetrates bone tissue, and of course the patient's clinical response. It's like a balancing act weighing all those variables.
So we need to be flexible and adjust our approach based on how the patient is doing. Are there any general rules of thumb that we can follow?
Well, For uncomplicated cases in children, 3 weeks of antibiotics is often sufficient.
Okay.
But adults typically require a longer course, somewhere between 4 to 6 weeks.
Right.
But again, those are just general guidelines, and individual cases might warrant adjustments.
Okay, so we've covered those key factors that influence antibiotic selection and treatment duration.
Yeah.
Now let's talk about those supportive measures
Sure.
that can help optimize patient comfort and promote healing. What's the AWARE book recommend?
Well, pain management is crucial. We need to make sure our patients are comfortable and able to participate in those physical therapy activities that are so important for regaining strength and mobility.
Right.
So we might use a combination of analgesics like acetaminophen or ibuprofen, and even consider stronger options like opioids in those cases of severe pain.
So it's not just about killing the bacteria, it's about addressing those very real and often debilitating symptoms that our patients are experiencing.
Exactly. We need to treat the whole patient, not just the infection. And along with pain management, immobilization of the affected limb can be crucial.
Okay.
For promoting healing and preventing further damage, we might use splints casts or even traction to keep that bone stable and give it time to mend.
It's like giving that bone a timeout,
Yeah,
allowing it to rest and recover without any unnecessary stress or movement.
exactly. And we also need to think about nutritional support. A well-nourished body is better equipped to fight off infection and heal properly.
Right.
So we might encourage a balanced diet rich in protein, vitamins, and minerals.
It's like providing the body with the building blocks it needs to repair those damaged tissues and regain its strength.
Exactly.
Now, before we wrap up this part of our deep dive, let's touch on those specific surgical considerations that the AWARE book outlines.
Okay, so while surgery isn't typically the first-line treatment for acute bacterial osteomyelitis,
Right.
there are certain situations where it becomes absolutely necessary. For instance, if an abscess is formed, we might need to surgically drain it to relieve pressure and remove that infected fluid. Or if there's a foreign body present, like a piece of metal or a prosthetic joint, surgical removal might be necessary to clear the infection.
So surgery is like our last resort,
Yeah.
but sometimes it's the only way to truly eradicate the infection and give those antibiotics a fighting chance.
Exactly. And in those cases of chronic osteomyelitis where those dead bone fragments are hanging around and harboring bacteria, surgical debridement where we remove those infected tissues becomes essential.
Right.
It's like clearing out the dead wood to allow new growth to flourish.
It's like giving that bone a fresh start, removing those obstacles that are preventing it from healing properly.
Exactly. And we also need to be prepared to address those potential complications that can arise from surgery, like bleeding, infection, and delayed wound healing.
Yeah.
It's like a high-stakes game with both risks and rewards.
All right, that wraps up part 1 of our deep dive into acute bacterial osteomyelitis. We've covered a lot of ground from those microbial culprits to those diagnostic tools and treatment strategies.
We've also touched upon those supportive measures and surgical considerations that are so important for optimizing patient care.
Stay tuned for part 2, where we'll delve even deeper into the pathophysiology and epidemiology of this complex infection,
We'll be back.
exploring those subtle nuances that can make all the difference in diagnosis and management.
See you there. Welcome back to the deep dive. Ready to delve deeper into this fascinating world of acute bacterial osteomyelitis?
Absolutely. In part 1, we covered those clinical basics, from diagnosis to treatment. Now, I'm eager to explore the pathophysiology. How do these bacteria actually invade and wreak havoc in the bone?
It's like a microscopic battle unfolding within the bone.
Oh, wow.
The AWARE book, chapter 35 specifically, outlines these different routes of infection.
Right.
Think of it as bacteria using various strategies to infiltrate a fortress.
Okay, so the bacteria are the invaders.
Right.
What are their tactics?
Well, sometimes they arrive in style, traveling through the bloodstream. This hematogenous spread often starts from a distant infection, like pneumonia or a urinary tract infection. Oh, okay.
Those bacteria are like stealthy operatives hitching a ride in the blood and then launching a surprise attack on the bone.
So it's not always a direct assault. The bacteria can infiltrate from within.
Exactly. And then there's the slow and steady approach where the infection spreads locally from adjacent tissues.
Yeah.
Imagine a soft tissue infection slowly creeping its way into the bone, like a siege.
Right.
Or those deep wounds that provide a direct entry point, like breaching the fortress walls.
Okay, so we've got the bloodstream invasion and the slow creep. What other tactics do these bacteria employ?
Sometimes it's a brute force attack, a direct inoculation into the bone.
Okay.
This often happens with trauma, like an open fracture or during surgery, where those bacteria basically get a VIP pass right into the bone.
Right, so those orthopedic procedures, while essential, can sometimes inadvertently open the door for these microbial invaders.
Precisely. And once those bacteria have breached the defenses and gained entry into the bone, they set up camp and start multiplying. And that's when the real battle begins, right? The body's immune system launches a counterattack to try and contain these invaders.
Exactly. And this is where things get really interesting.
Okay.
Because the bone itself becomes a battleground.
Uh-huh.
The immune system sends in its troops, white blood cells, inflammatory mediators, to fight off the infection.
So it's like a microscopic war zone with
Right.
those white blood cells acting as the frontline soldiers trying to eliminate those invading bacteria.
But those bacteria aren't defenseless. They've got their own weapons. Virulence factors that allow them to evade the immune system, survive within the bone, and even manipulate the host cells to their advantage.
Wow.
It's a constant back and forth, a struggle for dominance.
It's almost like a game of cat and mouse with both the bacteria and the immune system trying to outsmart each other.
Exactly. And as this battle rages on, we see those classic signs and symptoms of inflammation, pain, swelling, redness, warmth, and sometimes even fever and chills as the body mounts a systemic response.
So those symptoms are actually a reflection of the body's attempt to fight off the infection.
Precisely.
It's like a distress signal alerting us that something's wrong.
But here's the thing, that inflammatory response, while initially protective, can also backfire.
Oh.
Those immune cells release enzymes that can damage bone tissue, leading to bone destruction and those complications we discussed earlier.
So it's a delicate balance. The body's trying to fight off the infection, but in doing so, it can also cause collateral damage to the bone itself.
Exactly. It's like using a powerful weapon that can harm both the enemy and the surrounding environment. And this pathophysiological process can differ between children and adults, reflecting those developmental differences in their skeletal systems and immune responses.
That's interesting. What are some of those key differences?
Well, children's bones are still growing with a richer blood supply, making them more susceptible to those bloodstream infections.
Okay.
That's why hematogenous osteomyelitis is more common in younger children, often affecting those long bones like the tibia and femur.
It's like those growing bones are more vulnerable, providing those bacteria with easier access and a more hospitable environment.
Exactly. Now in adults, the bones are more mature, less vascularized, and arguably less susceptible to those hematogenous spread infections.
So adults are less likely to get osteomyelitis from those bloodstream invaders.
Right. Instead, we see a higher incidence of osteomyelitis caused by local spread or direct inoculation in adults, often associated with those risk factors we talked about earlier.
Right.
Trauma surgery and underlying medical conditions like diabetes.
So it's almost like the battleground shifts in adults with those local infiltrators and those direct assaults becoming more prominent.
Precisely, and this difference in pathophysiology highlights the importance of tailoring our diagnostic and treatment strategies based on the patient's age and those specific risk factors.
Okay, so we've covered the pathophysiology, those intricate mechanisms by which bacteria invade and damage the bone. Now let's zoom out and take a global perspective.
Yeah.
What can you tell us about the epidemiology of acute bacterial osteomyelitis?
Well, the Aware book provides some valuable insights into the global burden of this disease. And what's striking is that acute bacterial osteomyelitis isn't evenly distributed across the globe. It's more prevalent in low and middle income countries where access to healthcare sanitation and those preventative measures might be limited.
So it's not just about the bacteria themselves, it's about those broader social and economic factors that influence a person's susceptibility to infection.
Exactly. And even within those higher risk regions, certain groups are particularly vulnerable. We see a higher incidence in children, especially boys, and those with underlying medical conditions like sickle cell disease or diabetes.
So it's like a complex interplay of factors, both microbial and environmental, that contribute to the overall risk of developing acute bacterial osteomyelitis.
Precisely, and trauma emerges as a major driver of this infection worldwide, especially in those regions where road traffic accidents, falls, and violence are more prevalent.
That's like a vicious cycle.
Yep.
Those injuries create those entry points for bacteria, leading to a higher incidence of osteomyelitis.
Exactly, and it's not just about the initial injury. Those delays in seeking care, inadequate wound management, and limited access to antibiotics can further fuel the spread of infection and increase the risk of complications.
So it's a multifaceted problem that requires a comprehensive approach addressing both the immediate medical needs and those underlying social and economic factors that contribute to the burden of disease.
Now, shifting gears to high-income countries, we see a different pattern.
Okay.
Those trauma-related infections might be less frequent, but there's a rise in healthcare-associated infections. think about those cases linked to surgery-implanted devices and those increasingly resistant pathogens lurking within healthcare settings.
So it's almost like the battlefield shifts in high-income countries with those nosocomial infections becoming more prominent.
Exactly, and this shift highlights the importance of infection prevention and control measures within hospitals and other healthcare facilities. We need to be vigilant about hand hygiene sterilization techniques and judicious antibiotic use to prevent the spread of these resistant organisms.
It's a reminder that the fight against acute bacterial osteomyelitis isn't just about treating individual patients. It's about protecting entire populations and ensuring that our antibiotics remain effective for generations to come.
Absolutely. And speaking of those antibiotics, let's delve deeper into those treatment considerations that the AWARE book outlines.
Okay, so we talked about empiric antibiotic therapy in part 1, but once those microbiology results come back, how do we choose the most effective antibiotic?
Well, it all boils down to those susceptibility results. We need to make sure that the chosen antibiotic can effectively kill or inhibit the growth of the specific bacteria causing the infection.
It's like matching the antibiotic to the bacteria's fingerprint, making sure we've got the right weapon for the job.
Exactly. And we also need to consider those pharmacodynamic and pharmacokinetic properties of the antibiotic.
Okay.
That means understanding how the drug works, how it's absorbed and distributed in the body, how it reaches those target tissues, and how long it stays active.
So it's not just about choosing an antibiotic that can kill the bacteria in a petri dish. It's about choosing one that can reach those bacterial hiding spots within the bone and stay active long enough to do its job.
Precisely. And the AWARE book provides specific guidance on those preferred antibiotics for different pathogens and clinical scenarios.
So it's like having a roadmap guiding us through those complex treatment decisions. Now, what about those challenging cases where those first-line antibiotics don't seem to be working? What are our options then?
Well, sometimes we need to bring in the reinforcements, those second-line or even third-line antibiotics that might have a broader spectrum of activity or a different mechanism of action.
Okay.
But the key here is to consult with an infectious disease specialist.
So it's like calling in the experts, those specialists who have a deep understanding of those complex antibiotic choices and those resistance patterns that we need to be aware of.
Exactly. They can help us navigate those tricky situations and make sure we're using those antibiotics wisely and effectively now. Beyond those antibiotic choices, there are other important treatment considerations.
Like what?
Well, we need to think about the duration of therapy. How long do we need to keep those antibiotics flowing to ensure that the infection is completely eradicated?
That's a crucial question. Too short, and the bacteria might stage a comeback too long, and we increase the risk of those pesky side effects and antibiotic resistance.
Exactly. And the AWARE book provides some helpful guidelines, but ultimately the duration of therapy is individualized based on factors like the severity of the infection, the patient's response to treatment, and the presence or absence of complications.
So it's like a carefully calculated equation, taking into account all those variables to find the optimal treatment length. Now, before we wrap up this part of our deep dive, I'm curious about those special considerations for children. Are there any key differences in the treatment approach?
Well, in general, the principles of treatment are similar for children and adults.
Okay.
We aim for targeted antibiotic therapy based on those microbiology results, but there are a few key nuances to keep in mind. Children's immune systems are still developing, so they might be more susceptible to those aggressive pathogens and those complications of infection. We also need to consider those growth plates in their bones.
Right.
Those areas of active bone growth that can be particularly vulnerable to damage.
This is like we need to be extra cautious with those younger patients, making sure we're not just treating the infection, but also protecting those growing bones.
Exactly. And we also need to be mindful of those age-specific dosing adjustments. Children's bodies metabolize drugs differently than adults.
Right.
So we can't just use those adult dosages and expect the same results.
It's all about tailoring the treatment to those tiny patients, finding that sweet spot between effectiveness and safety.
Precisely. And communication is key, both with the child and their caregivers. We need to explain the treatment plan in age-appropriate language, address any concerns they might have, and emphasize the importance of adherence to those medication regimens.
It's a reminder that treating children isn't just about knowing the science. It's about building trust, fostering collaboration, and ensuring that those young patients feel heard and understood.
Absolutely. And speaking of collaboration, let's shift gears and talk about those multidisciplinary approaches that are so crucial for managing these complex cases of acute bacterial osteomyelitis.
Okay, so we've talked about the role of the medical microbiologist in identifying those culprits and guiding those antibiotic choices. But who else is involved in this team effort?
Well, depending on the specific case, we might have infectious disease specialists, orthopedic surgeons, radiologists, even physical therapists, all working together to ensure the best possible outcome for the patient.
It's like assembling a dream team, each member bringing their own unique expertise to the table.
Exactly. And communication is key. We need to keep those lines of communication open, sharing information, coordinating care, and making sure everyone's on the same page.
It's a reminder that medicine isn't a solo sport. It's a team effort where collaboration and communication can make all the difference.
Now, before we wrap up this part of our deep dive, let's circle back to those long-term implications of acute bacterial osteomyelitis. What are some of those challenges that patients might face even after the infection has been cleared?
That's a great point. We can't just focus on the immediate crisis. We need to think about those long-term consequences and how we can help our patients navigate those challenges.
Exactly. So even after those antibiotics have done their job, some patients might experience lingering pain stiffness or even those limitations in mobility.
So it's not just about eradicating the bacteria, it's about restoring function and helping patients regain their quality of life.
Precisely. And that's where those rehabilitation specialists like physical therapists and occupational therapists play a crucial role. They can help patients regain strength, flexibility, and those essential skills for daily living.
It's a reminder that recovery is a journey, and it often requires a multidisciplinary approach to help patients reach their full potential.
Now, beyond those physical challenges, we also need to be mindful of those psychological impacts. Chronic pain, fear of recurrence, even those body image concerns can take a toll on a patient's emotional well-being.
So it's not just about treating the body, it's about addressing the mind as well.
Exactly. And that's where those mental health professionals like psychologists and counselors can provide valuable support. They can help patients develop coping mechanisms, address those anxieties, and navigate those emotional challenges that often accompany chronic illness.
It's a reminder that healthcare is about more than just pills and procedures. It's about holistic care, addressing those physical, emotional, and even social needs of our patients.
Absolutely. And speaking of those social needs, let's not forget about the impact that acute bacterial osteomyelitis can have on a patient's work relationships and overall quality of life.
It's a ripple effect, with the infection extending its reach beyond the bone itself.
Exactly. And that's why it's crucial to involve social workers and other support systems to help patients navigate those challenges. They can connect patients with resources, provide financial guidance, and offer emotional support during those difficult times.
Okay, so we've covered a lot of ground in this part of our deep dive. We've explored the pathophysiology of acute bacterial osteomyelitis, those intricate mechanisms by which bacteria invade and damage the bone.
We've also taken a global perspective, examining the epidemiology of this infection and those factors that contribute to its burden worldwide.
And we've delved deeper into those treatment considerations, emphasizing those individualized approaches that are so crucial for success.
But our exploration isn't over. Yet stay tuned for part 3, where we'll put our knowledge to the test with a rapid-fire round of exam-style questions designed to challenge your understanding of this fascinating and challenging infection.
It will wrap up with some final thoughts on the future of acute bacterial osteomyelitis research and those ongoing efforts to combat this global health threat. Welcome back to the Deep Dive, fellow microbe detectives. Ready for the final challenge?
Absolutely. It's time to put all that knowledge we've gained about acute bacterial osteomyelitis to the test.
Yeah.
Let's see if you can diagnose these cases like a seasoned pro.
All right, get those thinking caps on. We've got 5 challenging questions coming your way, each based on the WHO's Aware book and those key points we've discussed.
All right.
Remember, we'll pause briefly after each question to give you a chance to ponder. Then we'll break down the correct answer, referencing the relevant information from our deep dive.
Sounds good.
Okay, are you ready for question number 1?
Bring it on.
All right. A 5-year-old boy presents with fever, refusing to walk, and pain in his right leg exam shows swelling and tenderness over the tibia. What's the most likely pathogen causing this infection?
Take a moment to think back to those common culprits in children. This one's a classic presentation.
All right, thumbs up. What do you think?
The most likely culprit in this case is our old friend Staphylococcus aureus, possibly even MRSA.
Okay.
Remember, it's the most common cause of acute osteomyelitis in children, especially in those long bones.
Exactly. And the clinical presentation, fever, pain, swelling over the tibia, all point towards a classic case of acute osteomyelitis. All right, on to question number 2. A 30-year-old woman with a history of intravenous drug use presents with severe back pain, fever, and chills. An MRI reveals inflammation and bone destruction in several vertebrae. What is the most crucial next step?
Ooh, this one's a bit trickier, but think back to what the WHO emphasizes in the AWARE book. What's the foundation for effective treatment, especially in adults?
All right, let's see if you got it. What's the answer?
The most crucial next step is to obtain blood cultures, AE, a bone biopsy for microscopy culture, and susceptibility testing.
Okay.
Remember, targeted antibiotic therapy is the gold standard, and to do that, we need to identify the specific bacteria causing the infection and its susceptibility profile.
Spot on. We can't just throw antibiotics at the problem.
Nope.
We need to know who we're fighting and what weapons will be most effective.
Absolutely.
Now, on to question number 3. A 70-year-old man with diabetes develops a non-healing ulcer on his foot. The area becomes increasingly red, swollen, and tender. What type of osteomyelitis is this patient most at risk for?
Remember those different routes of infection we discussed? Think about how the presence of a diabetic foot ulcer might change the game.
Okay, time's up. What's your diagnosis?
This patient is most at risk for osteomyelitis caused by local spread from that pesky diabetic foot ulcer.
Okay.
Diabetes impairs wound healing and blood flow, making the bone more vulnerable to those nearby bacterial invaders.
Exactly. It's like the infection has a direct pathway into the bone thanks to that compromised tissue.
Now for question number 4, a 10-year-old girl presents with pain and swelling in her elbow after a fall. An X-ray reveals a fracture. What other condition should be on our differential diagnosis?
This one's designed to test your clinical acumen.
Right.
Think about those conditions that can mimic the presentation of acute osteomyelitis.
All right, time's up. What's your second suspect?
We can't forget about septic arthritis.
All right. It can occur alongside or independently of osteomyelitis, and the symptoms, pain, swelling, tenderness, near a joint can be very similar. The fracture adds another layer of complexity, but we need to consider both possibilities.
Excellent point. It's like a medical whodunit.
Yeah.
And we need to consider all the suspects before we make a definitive diagnosis. All right, on to our final question. An 80-year-old woman undergoes a hip replacement surgery. Several weeks later, she develops fever, pain, and drainage from the surgical site. What's the most likely treatment approach for this patient?
Think back to our discussion about prosthetic joint infections. These cases often present unique challenges.
Time's up. What's the best course of action?
This patient likely has a prosthetic joint infection, and unfortunately, these are notoriously difficult to treat with antibiotics alone.
Right.
Surgical removal of the prosthetic joint followed by a course of antibiotics is often the most effective approach. It's a tough decision, but sometimes it's the only way to ensure eradication of the infection.
That's a wrap on our rapid-fire round. How did you do where you lay? Hopefully those questions help solidify some of those key concepts we've explored in this deep dive.
Remember, this is just a taste of the vast world of acute bacterial osteomyelitis.
Yeah.
The WHO's AWARE book is an invaluable resource for those who want to delve deeper into this fascinating and challenging infection.
We've covered a lot of ground in this deep dive. We started by unpacking the definition and classifications of acute bacterial osteomyelitis, those key distinctions that guide our approach to diagnosis and management.
We then delved into the clinical presentation, those telltale signs and symptoms that should raise our suspicions and prompt further investigation.
Right. We explored the essential laboratory tests, those microbial fingerprints and inflammatory markers that help us confirm the diagnosis and guide our antibiotic choices.
We even ventured into the world of imaging.
Yes, we did.
Those X-rays, CT scans, and MRIs that provide a glimpse into the battleground within the bone.
And of course, we tackled the complexities of treatment, from those empiric antibiotic choices to those individualized approaches that balance effectiveness with safety.
We also discussed the importance of supportive measures, those pain management strategies, immobilization techniques, and nutritional interventions that can optimize patient comfort and promote healing.
And we didn't shy away from those challenging cases.
No, we didn't.
Those prosthetic joint infections and those situations where surgical intervention becomes necessary.
It's all part of the picture.
But our deep dive wouldn't be complete without acknowledging the broader context of acute bacterial osteomyelitis. We explored the pathophysiology, those intricate mechanisms by which bacteria invade and damage the bone, and the epidemiology, those global patterns of disease, and those risk factors that contribute to its burden worldwide.
We also reflected on the long-term implications of this infection, those lingering challenges that patients might face, and those multidisciplinary approaches that are so crucial for comprehensive care.
It's a reminder that acute bacterial osteomyelitis isn't just a bone infection. It's a complex interplay of microbiology, immunology, clinical medicine, and even those social and economic factors that influence a person's vulnerability to disease.
Absolutely.
So as we wrap up this deep dive, we hope you've gained a renewed appreciation for the complexities of acute bacterial osteomyelitis and a deeper understanding of those diagnostic tools and treatment strategies that can help us fight this formidable foe.
Remember, knowledge is power. The more we understand about this infection, the better equipped we'll be to diagnose it early, treat it effectively, and prevent those long-term consequences that can impact a patient's life.
So keep those brains buzzing, stay curious, and never stop learning. The world of medical microbiology is constantly evolving, and we, as the guardians of microbial knowledge, have a responsibility to stay ahead of the curve.
Thank you for joining us on this deep dive into the fascinating world of acute bacterial osteomyelitis. Until next time, keep those microbes in check.
And remember, wash your hands.